Thank you for having me. And for once I have a pointer, so hopefully I'll be able to point out some things if you need additional help with that. I'll apologize ahead of time. I am from Pennsylvania and I do talk very fast. If you think I'm talking fast now, this is as slow as I can go, so prepare yourself. So I'm going to talk about the Proven Health Navigator, which is Geisinger's version of the medical home. And we started this in 2006. So we're going to walk you through our process, show you a lot of the things, not truly step by step, but the thing you get the biggest bang for your buck, and the things that I think will be relatable to you down here. Transitions of care, engagement of specialists, if you have an electronic medical record, ways to get that engaged to help your process. So Abigail Geisinger is the reason where we are today in central Pennsylvania. She gave an endowment of $1 million a long time ago, and we've continued to grow from that, and that allows us to have this Level 3 trauma center in central Pennsylvania that employs 10,000 people and gives top-level care in rural areas, which is where you guys are taking care of. So this is just a brief overview of the Geisinger Health System. You can see we have at least 2 acute care hospitals. We're actually up to 3 now. We have a children's hospital, heart and cancer center, women's center. We have, now it's currently 800 physicians that are employed through Geisinger with 40 community practice sites. 220 interns and residents in several programs. We do have a managed care organization, the Geisinger Health Plan, which I'm sure you've heard of, which allows us to kind of work with a lot of this, and you can see that we have over 1,000 contracted physicians with the health plan. And they are posting these slides, so if I'm not going to read every line to you, I'm just not a person that reads every line, so I apologize for that. This is just going to show you the scope of our reach in the Geisinger Health System. You can see this is Pennsylvania. We have 3 hubs, Western, Central, and Northeast. And then these are the main hospitals where they circle through. Grays Woods is our newest outpatient surgical center, the Geisinger Medical Center, Geisinger Northeast, and Marworth is our rehab facility for drug and alcohol. This is a list of all of our community practice sites and where they're located. And then the green squares are our CareWorks. These are the urgent care centers that are in the WISE markets, CVS, things like that for walk-in visits. And these are all the non-Geisinger physicians that are contracted with Geisinger that actually have access to our electronic medical record in their offices. So when they see a specialist at the main hospital, they can go into their record and see the physician's notes directly. Why do we need to change what we're doing for healthcare? This is actually an older slide, but I use it every time. It's kind of heartbreaking when you think that adult patients in this area are only receiving barely over 50% of the care that they need. This is what's recommended care for acute, chronic, and preventative conditions. So obviously we need to do something to redirect. We have a great country we live in, and we want to make sure our health care reflects that. So if you think doctors are busy now, this slide breaks down how much time a physician needs for everything you have to do. So for acute care, you need 4.5 hours for the day. For preventative care, you need 7.5. Chronic care is 10. So I don't know if any of you know a physician that's willing to give 22 hours a day to their practice. In today's society, I don't think you're going to find a lot of them. So we want to change the way we're delivering care, smart care, more population-based care, and evidence-based practices that take it out of the physician's hands and give us time to take care of the patients that we need to take care of. So the medical home, which is the PHN objectives, obviously what we want to do is transform primary care. So we want to give it more value. It's not just how many patients can you see in a day to make money, but if you take care of the population properly, can you take care of the right patients? These are the 5 goals that we always track through. We talk about these on a rolling basis at all of our meetings, making sure we think of patient-centered care, integrated population management, micro-delivery systems, the quality outcomes, and value reimbursement. If you can't prove that you're going to make money doing it, no one's going to want to do it with you. And I will break through some of those as we go through the slides. Patient care redesign, you want to get the patient and the families re-engaged in the process. I have a lot of patients that you talking about it, well, I don't know what that pill is, that's my little white pill. Well, which is your heart pill? Well, I don't know. So making sure patients and family are more aware of what they're taking medications for and what they're going to do if they miss those medications. Making sure the physician it leads the care, and we always carry that a care team with the physician in the center and then the nurse in the front office and a care manager to help assist in that process. Chronic disease and preventative care optimization, I think the electronic medical record is a huge help for that. There are health plan tools and paper-based products for sites that do not have an electronic record. We've been up on our electronic record for about 12 years now, so it is a work in progress. And this slide just really shows that it's a 360-degree patient care and navigation. The health plan helps, but we're reaching out from the center and want to get everyone in our whole community engaged in the process. So what's a value care system? Value care system is making sure you know your medical neighborhood and what's around you and what your best resources are. So who are your high volume specialists? If you look at your high volume specialists, who are the ones that are going to give you the best care? Who has the lowest complication rate? Who is the best bang for your buck when you go and send patients to this? Ancillary services, how many private radiology groups are out there and who gives you the best readings for what you're going to? You want to make sure that you're sending your patients to the sites where they're going to get the most benefit. Knowing the home cares in your area, the nursing homes in your area, which emergency rooms have a tendency to admit more patients. What are the community resources? Who does Meals on Wheels? Which churches have people that are willing to go and sit with an elderly person so someone can go do the grocery shopping? Having that in a central area and knowing what's out there is a really viable thing to have. So we use the health plan as kind of a partnership. The health plan can give us a lot of things, and as primary care physicians, we can do a lot of things. And so this is one of the ways we were able to get started and try medical home and keep it as a sustainable business. And we're at this point where we use the health plan to get us started, and I know you guys don't have a lot of health systems attached to you, but we're at this point now that if the health plan pulled out and didn't want to pay for it, we can sustain ourselves and pay for whatever they're dumping into our practices. So population management, if you can't keep your patients healthy, you're never going to stop it. So we want to make sure we stratify our patients. We do some predictive modeling. For example, we know at my practice site, I have 10,000 patients assigned to my practice site of 6 physicians. I know we have 500 diabetic patients in that practice. I know exactly where all they are. I know when their last visit to the doctor was. And we can reach out and grab those patients to prevent things. Health promotion, we do a lot of preventive screenings, health fairs, things like that are free for the community. Self-management, education, case management, and then pharmacy management. We've really been pushing generic medications in our area. Most of our medical home sites are up to an over 86% generic medication usage. And we used to talk about how much money that saves, and the one number was if you can increase your generic use by 1%, it's going to save the system over $1 million. Population-based care, the best way to think about it, you have all these patients out there, you don't need to see all 10,000 patients every year that are in your practice. There are a lot of things that you can do automatically. And so our automatic prevention for our patients, they get a letter once a year on their birthday, and it says, happy birthday, you're 50 years old this year, you're going to need a colonoscopy, you're going to need cholesterol screening, call our office and schedule it. And that happens on the back end. The doctor doesn't even know that letter went out. Once you already have a disease process like hypertension or diabetes, then you go up into the next section, which is the enhanced systems of care. And this is prompting our patients that you have a home blood pressure monitor, you can go in through a patient portal, give me your blood pressure readings so that I know where you are at home and I can see if you're controlled. It's in a patient portal where you can enter all your glucose readings right from home and the doctor can see them and adjust your medications as needed. Again, no touch in the office, but the physician can prompt out and say, something's really wrong, your sugar's 250, your sugar's 300, your blood pressure, you've got to come in for a visit. And so that's how we kept that second set of patients. The commando care management for the multiple comorbid conditions, these are the patients that our case managers touch. And these are patients with COPD, heart failure, recent hospitalization, recent surgery, that if you don't keep a close touch on these patients, and I think you all know them and you see them, they're the patients that are getting admitted to the hospital, getting readmitted to the hospital, getting readmitted to the hospital, to the nursing home, back to the hospital. These are the high utilizers. And I'm going to walk through how we've used the high touch and high tech things to bend that curve and decrease our readmissions for those patients. So this is our Proven Health Navigator. These are the general objectives, and this slide kind of permeates through the rest of the presentation, so as we kind of walk through that. These are the 5 components of our medical home, and we've already touched on the patient-centered primary care, integrated population management, quality outcomes, value reimbursement. I don't really have a lot of slides on value reimbursement. I'm happy to talk about you on the side how we compensate our physicians for this. I wanted to start and just talk on what we started since we did in 2006. We call some of our disease that we track bundles, okay? So we do diabetes bundle, coronary artery disease bundle, preventative bundle. Our newest is a hypertension bundle. We have a CKD bundle. So we're rolling out, and all a bundle is a way of compiling the most critical things for that disease process that you want your physicians to touch on. So for our diabetic bundle, I have a slide coming up that's going to show you the 9 things that we track. And once a month, we give our physicians their data, and we say, here's your 150 diabetic patients. This is how many of them had their A1C drawn. This is how many have a urine microalbumin. This is how many have had their eye exam. What do you want to do about the rest of it? To make it better, we incent our physicians to do better on the bundle. So coronary artery disease actually has 15 metrics that we track. Our preventative care bundle, depending on your age, has up to 32 metrics that we track physician by physician. So by using bundled processes of care, we have decreased readmissions, decreased admissions overall, patients are happier, and we have decreased the medical cost of this care. This is just a quick shot of our diabetic bundle, and you can see some of it is just getting the blood work done. How can you treat a hemoglobin A1C if you don't have a reading in your chart except from 3 years ago? So get it measured, and then are you at goal? Get the LDL measured, is it at goal? Blood pressure, urine protein, vaccinations, influenza, and pneumonia, very important, and then smoking status. So if a patient gets all of those, that means they hit the bundle. If they missed on even one of them, they're not on the bundle, they missed. So when we saw on the last slide, you're going to see the A1C less than 7 versus 7 to 8. There was a study that came out a couple years ago that perhaps patients with heart disease, it's not safe to have their LDL less than, their A1C less than 7 because of the risk of hypoglycemia. So we adjusted our bundle, to compensate for that. And if you think your patient's A1C, their goal really should be between 7 and 8, you can change that in the record and that'll satisfy the bundle for you. So Geisinger claims we're really good at preventative care and disease modification. You can see when we started, I don't know why it's going out, I apologize. Can you guys hear me if it does go, when it does go out? Okay. When we started with this, our bundle was 2.4% when we first started looking at diabetes. Okay, so this is how we tried to change the process. We're going to use electronic record as much as we can. We have alerts to the providers that tell your patients when they're due for things. The front office is going to schedule flu shots and pneumonia shots automatically. It's going to show up on the nurse schedule just to do that. The nurses have a standardized rooming tool so that every patient every time gets the same set of questions asked to them. And using our patient portal, which is My Geisinger, and some report cards. And I'm going to go through these processes with you. So this is a copy of the nurse rooming tool. It's a standardized set of questions that the nurses go through, and it makes sure they have a living will, their medications are reviewed step by step. So this is how we know asking the nurse to do something is better. We have My Geisinger as our patient portal into their electronic record. And we incented physicians, we actually paid them to enroll patients, and you can see December of 2005, nobody's using My Geisinger, no one's signing them up. In January of 2006, we asked our nurses to enroll our patients. And you can see up there, nurses are really good at getting our patients enrolled in My Geisinger using the portal. The same with the urine microalbumin. We put that as part of the nurse rooming tool. If the patient hasn't had it, the nurse orders it and they get it done. And you can see a nice improvement. Not that doctors aren't doing a good job, but they're really busy. And to be honest, if your patient's in there with heart failure, do you really care if they had a urine microalbumin on that day? Probably not. Okay. This is a snapshot of our patient portal for medical. This is for the diabetic patient. And so the patient can go in, they log on, it's completely confidential, and it will tell them what they're due for. You're due for an eye exam, you're due for this. And they can click it, it sends a message directly to my office, and we get them scheduled for whatever they need. Is that giving feedback to somebody? Okay. Okay. All right. These are the best practice alerts that our physicians see. Every time you open up a chart, when you're going to see that patient, it's going to give you this list of alerts that your patients have to act on. They have a check mark on them. These are all actionable alerts. So you can pick which ones you want to act on for the visit. There's an accept button down in the corner that you can't see on this slide. That'll take you directly to the order set page. So you can order whatever they're due for. This is the diabetic report card that we print out for all of our diabetic patients at every visit. It gives them their most recent blood work and what their goals should be. This is our goal to try to help empower our patients to know where they are. We did this standard. We had our nurses print it out for us for 2 years, and then we asked the doctors to do it. And I will tell you, I have patients that at the end of the visit, where's my report card? You didn't print it out for me. So they did get engaged, and they are interested in using the product. This is another snapshot of part of our electronic medical record. This is the health maintenance page, where you can go in and see with the red arrow what patients are due for, and everything else that they have done and when they had it done. So it's a really easy way to keep track. This is specifically for a diabetic patient, but if a patient had kidney disease or heart failure, there would be other alerts on this thing. This is also where colonoscopies get prompted to get our patients to have those done too. So when you're going to do that, the care gaps are what we call all these deficits in care. And so we'll do a screening roll of all of our charts, and we'll say these 10 people are 55, they should have had a screening colonoscopy and they haven't. and prompt out a message directly to the patient. Do you want a colonoscopy? We'll get you scheduled. And then the message comes back to the doctor and we order the colonoscopy for them. So we do that through letters, My Geisinger, transfers, and we have a whole other presentation where we talk about how much money we've generated from patients that probably wouldn't have come in and had a test done without our prompting and asking them to come in. This is just a rolling average. You're going to see how our diet bundle from we started this is February of 2007. You can see our bundle was at about 7.2%, and we've increased up, and now we're just under 13%. And obviously there's some up and downs on there, but in general we're really positive and happy with the results. This is a rolling trend. The light purple line is our LDL at goal of less than 100, our blood pressure control, and the blue is our hemoglobin A1C at goal. This is just a thing you can see from March of 2006 is that light blue line. That's when we got started. And you can see July of last year how the whole curve has been shifting to show that we've got more patients that are hitting more aspects of the bundle. And this is how we know bundled care works. So for stroke, non-bundled care is every other physician in our community. These are Geisinger contracted physicians. These are our private practitioners. These are good docs. Okay? They've reduced their risk of stroke by 13% and their risk of MI by 25%. So they're doing good care. For those of us that are using the bundled care, you can see we reduced our risk by 17% of stroke and our risk of MI reduced by 31%. So same set of docs, typically a lot of them have been educated at Geisinger too, but using a bundled and a set of process that prompts you to do this, you're actually saving lives. Microvascular, some changes, retinopathy and amputation. So again, every doctor in the community is doing a good job. They've reduced their risk of retinopathy and amputation, but we reduced our risk by 30%, which is 36% better than the other doctors in the community. And amputation, we reduced by 60%. When we did the math, since we started the diabetic bundle, we prevented 75 amputations, is the way to think about that. So it's not a very big number, but if you were someone who was about to lose a toe, it's a great number. So we also do our adult prevention bundle. This is how we do our population management. This is how we keep people healthy, keep them from getting these disease states. We started this in January of 2008. And this was our 2010 quality data. This is the national average of getting these things done, the Geisinger clinic rate, the Geisinger health plan rate, and a Midwest plan, which is one of our competitions. And you can see the Geisinger clinic rates are higher overall in all the critical areas. And this is just through bundled and prompt messages in the chart. This is our adult prevention bundle, and you can see it's broken up by age and then by sex, and you can see it goes through, so there is a large number that people are eligible for. When we first started our adult prevention bundle, and again, our docs all thought we were doing a great job. We had 203,000 patients that qualified for the adult prevention bundle, and our baseline rate was 9.2%. So when you start thinking about bundles and is it working, is it prompting, you got to feed back to your docs. If you ask them something and you give them data from a year ago, that means nothing. If I ask you to do something today and I'm not going to give you data, like next year I'll come back and tell you how you're doing, you're going to do it for about a day and then you're done, okay? So we roll back this data to our physicians on a monthly basis. Every physician can roll out and look at their data down to a patient level every day if they wanted to. It's a rolling website through our electronic record that we can prompt. How do we keep these things going? We really talk about our monthly medical home meeting, having the health plan to help us, using the case managers in the office, and the data, making sure that the patients and the physicians see the data and are able to act on it, that it doesn't, like, I don't know what that means. That's from last year, okay? So when we started medical home, this is our rollout. We did it in 5 phases. We started with 3 sites, then up to 10, 12, and we have a total of 78,000 patients enrolled actively in the medical home site. It's not just Geisinger clinics. We have 7 private practitioners in our area that have engaged in medical home too, and their data reflects the same shift in the curve that we have. This is how we start from picking what patients are going to be enrolled very aggressively with a case manager. We do the predictive modeling based on how much money each patient has cost, and then you can go through and decide do they need to be enrolled in medical home or not. So if it's a lot of times a total joint replacement will pop up on the list. They're otherwise healthy. They need followed for about a month or 2, and then you release them back. You don't need to be case managed anymore. But if you have end-stage heart failure and your EF is 5%, your case manager is going to be touching base with you at least once a week forever because there's going to be a problem coming up. We use our electronic record again. This is a prompt for the front desk when someone calls to schedule an appointment. And it's going to prompt right on the bottom there. It says the medical home patient in active case management. So when these patients are calling for an appointment, the front office knows right away. They're going to be able to tell the case manager, Mrs. Smith called, what do you want to do? So we use the electronic record to give us a lot of help. This is our diuretic titration protocol, which we started right when we started medical home. This is a standard set of orders developed by our cardiologist that's an expert in heart failure. And the nurses the case managers give our patients a Bluetooth scale, and it sits at home. Our heart failure patients are advised to step on that scale naked after they pee first thing in the morning. And that's all they have to do, just step on the scale. That weight automatically gets dumped into a pool, and it triggers to our case managers. The case managers get an alert saying, Mrs. Smith is on our scale, it's fine. If her weight is up, then it gets a red flag, says you need to call Mrs. Smith. A 1 or 2 pound weight gain will prompt an automated call to the patient, and it's a series of 4 questions, and if the patient answers yes to any of those questions, like do you feel more short of breath, are your legs swollen, that prompts an alert back to our case manager, call that patient. So we know right away, and our case managers are calling our patients with a 2 pound weight gain. Instead of that, I went to the county fair and I had deep fried Oreos, which are my personal favorite. And now I'm up 10 pounds, and now I'm on my way to the hospital because I can't breathe. So that titration protocol, it's a set of diuretics, and if they trigger more than twice, they need to come in and see the physician. But if they just trigger once and they go back to the normal weight, then that's all that happens. This is a copy of our heart failure action plan that we give to all of our patients. This is how we're trying to get them engaged in self-management and education. We have another smart set and what we call a rescue kit for our patients with COPD. This is a set of antibiotics and prednisone that they keep at home. The classic COPDer, they know when they're going to get sick. They know when their cough starts. And no matter what they present with, if they come to see you and you're giving them an antibiotic and prednisone. So now we've empowered this subset of patients to treat themselves. When they feel they're getting short of breath or coughing, they start their rescue kit and they call the case manager. That prompts the case manager to call them every day for the next 3 days. If they're feeling better, that's the end of it. The patients are better. But if they're not getting better, the case manager knows to bring the patient into the office. Okay. So I have some data coming up that shows you how we've actually bent the admission and readmission curve for those 2 diseases based on just using those 2 processes. Best practice alerts, again, we have a bunch of different ones. These are more actionable ones that you can see. One for CKD, which triggers their hemoglobin, their phosphorus level, whether or not they're on an ACE or ARB, and if we want to adjust their medications. This is the one we do for coronary disease with aspirin, because we found out that despite the fact we're doing a good job, we were only at about 95% of antiplatelet therapy on our coronary disease patients. So we have a new prompt that tells them, do you want to put this patient on aspirin? So every medical home meeting, we meet once a month. It's an hour-and-a-half meeting. We have someone from the front office, someone from the nurse, physicians, the case managers, and someone from the health plan to bring us additional data if we need it. So we talk about workflow and process issues. If you don't know, I think I know how things work in my office. I think I know what happens when a phone call comes in if someone's short of breath, who gets that call, but maybe I don't. And it turns out I really didn't. Unless you're in there talking to the front office, you don't know. So you have to start drilling down and asking them, and they have to feel empowered to say, we're not getting the phone calls to the people we need to get them to. So we look at process and flow every meeting, every time. We look at case studies. We like to look at readmissions. We pick out subsets of diagnoses. Someone that was in the hospital for 1 day. Why were they only in the hospital for a day? Did they need to be? Could we have treated them in the office? And then we look at the metrics so we know what's working, what's not working. This is just a snapshot of the flow sheet we use when we talk about cases at our medical home meeting. The case manager, was the patient enrolled in case management before they got sick? Did we send them to the hospital? What disease processes they have? What have we done in the office? How could we have done it differently? And we look at it from a patient, but we look at it as a process. So we've targeted atrial fibrillation as one of our first processes because we were sending patients to the ER with AFib. They were there overnight and they were home. What were they doing in the ER that we couldn't have done in the office? And it turned out, unless they were unstable, they weren't doing anything. So we have a new process for AFib and how we're addressing that. We talk about the case manager. We need a case manager in every office. This is how we break them down. We do 1 case manager per 800 Medicare lives and 1 case manager per 5,000 commercial lives. So that's how we decide who goes in what office, and we break it down. The case managers carry about 150 patient panel. That's it. It's a rolling panel. If you have COPD or heart failure, you're going to be followed by the case manager forever. If you had a total knee replacement, you're going to be followed for 1 month or 2 months. Okay. So we just try to keep that. And then you can see that there's transitions of care and direct phone lines and how that works. Patient-centered, this is a difficult one. I'm sure everyone's trying to address how to get the patients more engaged in their care, more activated. And we work on it on a rolling basis. We have a lot of tools where we try to get the family members in with these patients. There's nothing worse than a demented patient who just got out of the hospital. Family's out in the waiting room, they're in your exam room by yourself. What happened to your meds? Well, I don't know. Why did you come by yourself? She's in the waiting room. Well, bring her back. Let's talk to someone who knows and can get these med lists done. And we spend a lot of our time, what we started doing is every patient that gets discharged from the hospital gets seen in my office within 3 to 5 days. Most importantly for med reconciliation, because the meds are always a disaster. Patients never understand the change. They don't want to make a change until they talk to their doctor who knows them. I'll give you the example of how one process actually worked. I had a patient who went in with chest pain. He had a heart catheterization, had a stent put in, was sent home with a script for Plavix. Saw me 5 days later, pulls out of his pocket his Plavix prescription and says, "What do you want me to do with this?" So guess who ended up back in the hospital with a restenosis, okay? So that's an extreme example, but that very glaringly brought a process out there that was a gap. So now at Geisinger, if you go in and have a stent, you get sent out with 30 days of Plavix in your hand. They actually give you the pills. So some of the things that we really work on, the heart failure, the COPD, these are the two big diagnoses. This is the bulk of your hospital admissions, to be honest. I will tell you, after I started doing the medical home, I actually work at one of the CHS hospitals. And within 1 year of doing medical home, I got called into the CEO and he asked me why I wasn't admitting any of my patients to his hospital anymore. And I said, I'm not. They're just at home. I'm not sending them to another hospital. I'm just keeping them out of the hospital. So people feel that pinch a lot. Step 2 in the whole process, it's good enough to do CHF and COPD, is the nursing homes. There's a big black box out there. Doctors, some doctors we don't know around at the nursing homes. Most of our doctors do it because we tell them they have to do it. It's not their favorite thing to do. They do it as an afterthought, after work. I'll go once a month just because that's what the regulations say. And that's a huge population of patients that are being discharged from the hospital, sicker and sicker, going to a nursing home, and poof, they're right back in the hospital. So we're working now on transitions of care to keep them in the nursing home and getting care there. Why do we need to fix it? This is nothing you guys don't know. 1 in 3 patients that are admitted to the SNF have to go back to the hospital. Average length of care, the long-term care patients, about 2 to 4 hospital admissions a year. So we need to do something different with this population. So what we've done is we have a SNFIS program that we've been doing. We're in year 3 now of the SNFIS program, which the SNFIS is a skilled nursing facility. And this advanced practitioner is in the nursing home every day. Full-time job. That's all she does. And what she does is med reconciliation. So she sees the patients, they come out of the hospital, she sees them right away. Makes sure their meds are up to date, making sure everything's good, that they're well in tune, they're feeling comfortable in the nursing home. So we actually did this as a role. This was a new job, so you have to do a job description. They have to see all new admissions within 24 hours. Any patients that's in the nursing home on a skilled reason, say a total knee or a total hip, she sees them 2 to 3 times a week. She communicates with the case managers that are also following these patients at least once a week, keep them updated on their plan, when are we going to get them to be able to go home. Long-term patients she sees once a month. And we do a health assessment tool that we do once a year to make sure patients are hitting all the standard requirements that they need. The other thing they do is we need to make sure that not just the hospital discharges that we're seeing in the office, but our patient being discharged from the nursing home needs seen in my office too, just as critically as a patient coming from the hospital. So our SNFist arranges a 7-day follow-up with the primary care doctor. She sends them a copy of their nursing home discharge paperwork. And she does all her documentation now in our same electronic record that we use in the office. So at any time, if I have a patient in the nursing home and I wonder how she's doing, I can go in and look, and all of my SNFist notes are right there for me to review. So one of the things we've started working on is decreasing the readmission rate back to the hospital, and this is how we do that. Is it working? It is working. So the light blue is our nursing homes that have a SNFist in them. The dark blue are the nursing homes that do not have a SNFist in their facility. And you can see that from year 1 to 2, admissions are staying fairly stable whether you have a SNFist or not. But readmissions are going down. You can see the dark blue that the readmissions in the non-SNFist facilities are climbing, where ours are staying fairly stable. Readmissions, again, ours are actually dropped a little bit, whereas the non-SNFIS groups have increased slightly. ER utilization, we're staying flat. If you have a SNFIS in the facility, non-SNFIS facilities had a 29% increase. So this is just another view of the ER utilization per 1,000. You can see how that works. This is just a snapshot of the 6 nursing homes that we first started out in, and you can see the decrease in readmissions from when we first put the SNFIS in 2008 to 2009. So when we do medical home, it's not enough just to say we're doing it. You got to reward people for doing it. It's extra work. It's a different way of thinking. So how do you give someone money if you don't have any money? Okay. So we're going to do quality metrics, and we have every year we have a rolling set of quality metrics that the physicians and the staff have to work toward. And if you get 9 or 10 out of these quality metrics, you get your money. Okay. If you don't really get it. So this is when we first started, and we started looking at quality metrics. They were pretty easy one. Increased patient visits. It's more care in the office, not less care in the office. Making sure that you're working on your bundles. Making sure you have heart failure documentation plans in their record. Making sure you're seeing the patients within a week of discharge. Making sure the case managers are calling the patients. And then this is when we first got our NCQA certification. 2010, we changed the metrics a little bit. We continue to focus on the bundles. But then we've added patient satisfaction. So we've sent surveys out to all of our medical home patients. Let's make sure that we think we're doing a good job. We think we like it. Do the patients like it and see a difference? We also wanted to start working on efficient specialists. I hinted on this a little bit, which knowing your specialists in the area. But what we found is there are specialists out there that cost more than other specialists. So it's important as a primary care doctor to know which ones, giving the same level of care, are going to cost you less, and preferentially pushing your patients toward those specialists. I'm embarrassed to say they're not all Geisinger specialists on the list. So we put the list out there. It's for everybody. This is our most recent quality metrics for 2011. This is what our staffs turned in for actually December of last year. And again, they're working on this. They have 1 more month. The bundles are really top and center again. And then we started working on advanced illness. So we're really working on something called PULSE, which is the physician's order for life-sustaining treatment. You guys probably use a lot more. It's new to us. We're working on it. Making sure we have advanced directives in the chart, making sure we've addressed these end-of-life issues with the patients before they need it. Also, again, patient satisfaction. We're trying to make sure we decrease our nursing home readmission rates and implementing a quality improvement project. So this data ends from 2009, but 2006 is our base year. This is our COPD metric. The first stop is our phase 1 sites. And you can see that they've had, from year 1 to 2, on COPD admissions, they had a decrease of 22% in COPD admissions. And on inpatient phase 1, this is med surg admissions, decreased by 31. Phase 2 sites of the second set of rollout, they also had a decrease in admissions, a slightly lower than the phase 1 sites. And phase 3, same thing, again, a decrease in their admissions and readmissions. This is our heart failure data, again, from 2006 up to current. And you can see across the board a decrease in admissions for CHF. This is where we've been working on with the bundles. This is the data we bring out every year, every month to our docs, show where they are. You can see our baseline data for diabetes is 2.5%. We're currently up to 12.5%. And these are in patients that hit all 9 out of 9 on the bundle metric. And it's 24,000 patients this is taken care of. This is our coronary artery disease bundle. We started this in 2006. We started at 8%. We're currently up to 24% of our 15,000 patients have all their heart disease metrics done. Adult prevention is our newest one we've been working on. We started at 9.2%, and we are up to 31%. This one seems like such a no-brainer. All the sites embrace this very easily. A lot of these things are nurse-driven protocols now that our nurses can give a tetanus shot if their insurance covers it. They can the BMI in the chart. They can order the lipid screening and diabetic screening for us. So it's not enough just to have primary care doctors engaged. You got to get the specialists engaged too. We used heart failure right off the bat to help us do the diuretic titration protocol. Osteoporosis is an up-and-coming thing. There's more and more of it. So we partnered with rheumatology to do standard DEXA orders. And now rheumatology will scan through our charts and say this patient's due for a DEXA scan, sign off on it, we get it scheduled. We have a mobile DEXA unit that comes to all of our community practice sites, so our patients don't have to go anywhere. They come right there, they're coming to see me, and they go out the door and get their bone density scan. Hypertension is a newer pilot. These are for our patients with uncontrolled hypertension, systolic greater than 160 on more than 3 medications. And we think they probably need to see a nephrologist to help manage their care. We're doing a diabetic project with endocrinology, and this is a high-touch program where a diabetic care educator is right in the primary care site. She talks to an endocrinologist that's back at the main campus and gets direct one-on-one care with the patients. Transitions to care is the big one. This is our newest project that we've been working on. And what it really tries to focus on is we know that first 3 days when a patient gets discharged from the hospital is when they're at the most risk to go back and get readmitted. So we need to grab our patient then to make sure that it doesn't happen. So we get to make sure the care managers call the patient within 24 to 48 hours. It's a telephonic reach. They make sure they do all their med reconciliation. They make sure there's home health involved if they need. If the patient was discharged and said they need oxygen, do you have your oxygen at home? What do I need to do to make sure you have your oxygen? Do you have stairs in your house and it turns out you got discharged from the hospital and the ambulance had to carry you into your house and you're never getting out again? What do we do to facilitate that? Do you need home physical therapy to come in and re-educate you on how to do stairs? Also, do you have an appointment to see your doctor? Does your doctor even know you're in the hospital? Maybe not. It's easy if you're at the hospital that I'm rounding at. I saw you yesterday. I know you were in the hospital. I discharged you. But say you're at Shamokin Hospital, which is 20 miles down the road, not part of my electronic record. Do I even know you were in? How do we capture that? And that's what our Transitions of Care team has been working on. This is some of the people that are on our Transitions of Care team: the hospitalist, the emergency room, nursing, social worker, and someone from the nursing homes comes in. Right now, the Transitions of Care does not meet always separately. They meet as part of our monthly hospitalist group. Hospitalist group, we look at all the readmissions, and the Transitions of Care is part of that big meeting to say, what can we do differently? So one of the things we've prompted with is someone make sure, if I know you're going home tomorrow, I send a message to your primary care doctor and I say, I'm discharging Mrs. Smith tomorrow. These are the 3 medication changes I did, and make sure you come in and see her. So working on that and streamlining that so I'm not the person causing the problem, that we've at least outreached to somebody so they know their patients are leaving. So we want to make sure that we're going to connect to the specialists too. And these are the diseases that we focus on most with specialists and trying to catch the patients early. What we found out was if you live up in, you saw our map of Pennsylvania, it's a big state, and it's geographically it's awful to drive. There's a lot of hills, it's not lovely and not as flat as down here. So a patient that lives up in Schuylkill County, if they need to see a rheumatologist, there's no way they're driving 40 miles to see a rheumatologist. They would rather just wait. So that's how we've been reaching out to them. Okay. When you're going to do medical home stuff, this is the Transitions of Care management. It takes about 3 months, so you can see data improvement. Case management for the high-risk patients, that's 3 to 6 months. This is just a flow of how quickly, if you're going to implement something, you're going to see a result on the back end. So very easy to get readmission data and decrease your readmissions in 3 months, which is a nice return on investment pretty quickly. So I think our market, unfortunately, is slightly different than yours, and this just kind of outlines it. So about 50% of our health plan patients are covered and treated by me and my fellow partners. 50% are by paneled physicians that are outside the Geisinger system. So what we do is we track our HEDIS measures, which is the health plan data, and anyone that works through the clinic actually has statistically higher data. So we know that what we're doing works in our system. And it's just a little prompt for us. So, we're working toward the pay for performance. We've been trying the PGP demonstration project and other things to see if that works. And one of the things we started doing was paying our physicians for quality, for the data. So for our bundles, physicians can get $8,000 a year if they perform high enough on their bundle metrics. They get that in twice a year increments of $4,000 if they hit on those metrics. So do the physicians like it? And this is just, we asked our physicians, do they think that monitoring management of patients has improved? And you can see over 70% agree or agree strongly. And then we asked them, does medical home allow you to provide more comprehensive care? And again, the answer was yes. This was just a question to the patients. Do they think the case managers are responding to your concerns? And it was yes. And the effectiveness of the case manager in working with the patients, also very good and good. Just another couple questions. How often did the primary care doctor give you clear instructions on how to manage a condition? And again, pretty much always. So this is just a quick slide. Yeah, having electronic record helps, but I have a physician who I call, he has yellow blindness because he can't see the best practice alerts no matter what we do. So the tool will help. The question is, we keep rolling back to these doctors, what do you need me to do differently? What can we help you to do to help continue to work? And what we found out is the more timely the feedback is, the quicker you can say, this is where you started, you did 2 little things, this is where you are now. It's a no-brainer. Compensation helps, but giving someone money only works short term. It's not a solid fix, okay? So, you know, we know the case management, the patients like working with the case managers, they think they're getting better care. And the providers, again, like working with medical home, getting more timely information on transitions of care. And these are the phone calls and the messages, even faxes from the hospitals that don't have an electronic record to make sure that you at least get a 1-page set of data on what happened to your patient during that hospital stay. And this just says I would recommend Proven Health Navigator to other physicians, and most of our physicians say yes. This is going to show you just our data overall. This slide takes a little bit of explaining. The 2006, that black dot, that 294 per 1,000, is all 37 sites, their baseline data, even though some of them were not medical home. So the blue is our improvement in acute admissions per 1,000, and the gray are the non-medical home sites, okay? So you can see that we've been decreasing our admission curve, whereas the non-medical home sites are pretty much holding stable. This is our readmission data. Again, 2006, that's our baseline. And you can see readmissions per 1,000 went down from 43 to 41, 31, 34, 34. Now, the non-medical home sites had a slight decrease too, but not as big as ours. ER utilization, this continues to be the bane of our existence. I don't know why some people go to the emergency room. It's not always nighttime. It's not always because of something critical. ER utilization, these are patients that went into the emergency room and got discharged home. These are not patients that were admitted. And you can see we've stayed fairly flat despite all of our innovation, and the non-medical home sites also. This is some of our commercial data. We started doing commercial about 2 years ago. 2007, we only had 1 site up on commercial. But you can see that ER visits have decreased slightly. And acute admissions, again, for commercial has decreased slightly. So this is the curve. This is going to tell you how much less money we're spending, and there's actually been a 6% decrease in our cost curve here, and this is statistically significant. You can see where we were initially, and then since we've implemented medical home. So we decreased by 6%, where everyone else has been about a 6% increase, so it's about a 12% delta. And this is just continuing to, we reinforce on a rolling basis. We actually stipend our physicians to participate in medical home, and the department directors in each site decide who gets that money, who doesn't. So if you have a physician that does not participate, that's not agreeing to take care of the patients the proper way, they don't get that additional money, and it's very clear that they're not getting it. And we also, I know everyone's heard about Geisinger, and we made the New York Times. So I'm going to talk a little bit about how our outreach to specialty. We've been working on rheumatology, pulmonary, endocrine, and new one is ER utilization and pediatric behavioral health and end-stage renal disease. Our emergency room, we're just getting up and started, but now we're able to get from CMS the data on who our utilizers are. So we get a sheet once a month that has any of our Medicare patients that have been to the ER more than 3 times. And then it breaks it down, what were they in the ER for, what time of day were they in the ER. Which is kind of nice when you look at that list and like, oh, I didn't know she was in the ER. So, but it lets you kind of control. When we started looking at this, we had one patient at one of my Coltmont sites, and he had 9 ER visits, and they were all for back pain and muscle strain. He was definitely narcotic shopping. So we bring that to our attention, let the doctor address that with the primary care doctor. So obviously we work on heart failure. The interactive voice response is what I hinted at, that it calls the patient and they answer questions, and if they get any yeses, it prompts for the case manager to call the patient directly. And we're working on in-home video and inhaler adherence. We do a lot of pill boxes for our really sick patients, where we fill it once a month, and then you can see the patient at the end of the month, you get the pill box back, you know what they took and what they didn't take. So these are the 4 areas, the specialists that we've been doing the most outreach with, and hopefully we have the most data to explain to you what's been going on. This thoracic medicine, rheumatology, the nephrology and diabetes, and hypertension. And really what we wanted to do was make sure that the medical home could integrate with these specialists and help improve care for the patients. So thoracic medicine and rheumatology, this is the most exciting data we've done with because it uses video exams, which is kind of neat. I'll walk you through that. And this just walks you through, obviously you have the primary care and the patient, and then you're going to consult a specialist. And some patients only need to see a specialist once, and then they go back to what they're doing. Other patients are going to need to continue to see the specialist for the rest of their life. So where are you going to trigger and what are you going to do to help take care of these patients? So what we've opted for to trial is telemedicine, and we've been doing this for 6 months now at 2 of our sites. So we do telemedicine visits for COPD, for solitary lung nodule. We do them for rheumatology, for osteoarthritis, for rheumatoid arthritis follow-up. And it kind of gets scheduled. This is just a stepwise process. The patient comes to their own primary care site. It's the same site they see their regular doctor at, and then the process is how they trigger the specialist down at Geisinger saying, your patient's here for the visit. Let me know when you're ready. The nurse gets the patient in the room, gets everything ready to go. The physician interview with, obviously if the physician specialist is not ready, they wait. Once that is, you can turn on the teleprompter, and it's a big video screen. You talk back and forth with the patient. And then when they're ready to do the exam, they prompt and the nurse comes in and does the monitored exam for the physician. And then you can complete the visit, same as any other visit, and reschedule up. So patients really like this. This is just a scan of what the nurse-assisted physical exam looks like. And we train these nurses specially to do these visits. They actually have a stethoscope that the physician in Geisinger can listen through the airwaves. Doesn't have to be right there because the physician listens to the chest. And so far we've been doing it. We give everyone a survey when they've done it, and it's been very positive. And so this is just some of the areas that we've continued to work on: the uncomplicated patient, the moderate complexity, and complex. And the majority of these patients are followed up telephonically. And in the primary care visit, only one has had to make actually the drive down to the main hospital to see the specialist in person. Diabetes is the next thing we've been working on. I think diabetes is a pervading problem across all of the United States. And we want to continue to coordinate care. There's obviously not enough endocrinologists out there to get to every primary care site. Our endocrinologist is a wait list 3 months long to get in to see them at the main hospital. So we put a diabetic educator in each site, and she speaks with an endocrinologist at the end of the visit, and it's all electronic, and he supervises. She can start medications, he signs off on them, she can adjust medications, and it's kind of a nice way to do that. She sees them on site for an initial 1-hour evaluation, and then she follows them up with a half-hour visit. She sees them for a total of 12 weeks. At the end of the 12 weeks, she reassesses their blood work. If they're not at goal, she re-enrolls them for another 12 weeks. If they're at goal, she releases them back to our primary care. This is just some of the data when we started doing it. You can see that the decrease in A1C is pretty nice. And patients understand it. They like it. They like going to see somebody and not having to leave their primary care office. Just geographically, what I always hear is, I'm not driving over that bridge. There's no way I'm doing it. It's a bridge. But they just see that as the distance they have to go to the hospital to see a specialist. The providers like having it. It's really nice to have someone getting specialized diabetic care right there in your office. You get the feedback immediately. Again, it's in the electronic record, so it does help us out quite a bit. This is a graph of how we pulled our patients to see who got enrolled in the program. You can see we used the diagnosis of diabetes and their A1C. They had to be over 18. They had to have, we started with just the Geisinger insurance. We have subsequently released that, and we take all insurances into this diabetic program now. And then have they had an A1C or have they not? If they haven't had an A1C, let's do an outreach and say, come on in and get your blood work done so we can see where you are. Maybe they're back at goal. If they have not, then when you get the blood work, where are they? Are they just a little bit out of range? Are they a lot of it out of range? When we started this program, my second patient that they called had an A1C of 14%. So there are definitely some needs out there. So what we wanted to do is improve our HEDIS score. We wanted less patients with their A1C greater than 9. We wanted more patients to improve their diabetic bundle. We did standardized questionnaires. And this is how much it costs to have a diabetic educator in your site. So for 3 months, or 0.4 versus a 0.2. And the endocrinologist oversight is still a heck of a lot cheaper than having to have an endocrinologist full-time in your office. We did phase 1 where we pick and chose some patients. The top group, CDE, this is our diabetic educator. She had 70 patients, and she was able to get their A1C dropped by 1.9%. The nurse practitioner and the health educator, this is the GHP, that's a telephonic outreach where someone's calling you on the phone saying, I see your sugar's not good, versus a nurse practitioner doing it, and they were only able to decrease by 0.1%. So hands-on really does work in that situation. And again, we follow these up with a survey. Did the patients like the visit? Did they get what they wanted out of it? And you can see that overall the follow-up is really positive. Hypertension was the next one we reached out to. We actually did this at Napper Clinic, which is one of our larger primary care sites, pretty close to the main hospital. Again, we looked at patient lists and we found 37 patients, 27 of them which had the health insurance that hit the criteria. And as of June, when we first did this data, we had 19 of these patients were seen. And you can kind of see there who was seen. So they get seen once a month for their hypertension. They get more education. There's standard protocol for physicians to use to adjust their medications and making sure, one, that the patients are checking their blood pressure appropriately at home. When they do come into the office, initially they have a 45-minute visit with a nephrologist, and then they have a nurse educator, and then they get followed every 2 weeks with a blood pressure check or weekly. Any questions about that? I went over an hour, guys. Questions? Yes?
I live in a county in North Carolina, one of the 10 poorest in the state.
So no troubles there, huh?
How dependent upon electronic medical record and internet access, and particularly when we get into the older Medicare poor population in our county, either they don't have a computer in the home, or if they do, they can't afford internet access. What percent of your patient population doesn't have internet access, and how does that impact your ability with this model?
So the best way to track that is through our patient portal, the MyGeisinger. We have about a 25% penetration of MyGeisinger use. So I don't know if everyone who doesn't have MyGeisinger doesn't have internet, but about 25% of our patients are electronically accessing us for care and looking at their records and helping out. So that's 75% of our population that does not use the internet for anything to communicate with us health-wise. And the 7 sites that are not Geisinger sites, those are all paper record sites. So they've been doing it, again, with a paper record, with a paper prompt and the survey and a paper checklist. And same thing, those patients get a paper mailing, go out at home, answer these questions, bring this paper back with you to your doctor, things like that. But it is more of a struggle. The patients that you can engage in a portal, that will send you blood pressure readings and sugar readings once a month, it's so much easier to manage them. Yes?
That was an impressive presentation. Thank you for sharing with us.
Thank you.
Question on your SNFs and the relationship with those nursing homes that were not part of, or long-term care facilities that were not part of your system.
Yes.
Did you place the SNFs there?
Yes.
Did the long-term care facility participate in paying for that?
No, we pay for them 100% ourselves from whatever site we put them in. So, for example, my SNFist is at 2 nursing homes. She spends 2.5 days a week at Penn Lutheran, 2.5 days at Nottingham, and she splits that. When we first enrolled her between the 2 nursing homes, we had 60 nursing home patients in those 2 facilities. Since we've got her helping to take care of us, we're up to 110 patients at those 2 facilities. So it lets. There is one nursing home or SNFist out in the west that actually wants to help pay the SNFist to take them there, but we have not. So far, we've just been paying for them ourselves.
Second question, sorry. You mentioned non-medical home sites.
Yes.
Did that include urgent cares by any chance?
So non-medical home site is any other office or facility just in our area. So yeah, urgent care would be part of that too. Geisinger owns a couple urgent care sites, and what we try to do is if someone gets seen there for a problem and they have, say, diabetes or hypertension and they do not have a primary care doctor, we try to get them to send to one of our community practice sites that's close geographically for that patient. But if they get seen in our urgent care site and say, Dr. Smith down the road is their doctor, we send him a message saying, your patient was just in, you got to see him back.
Thank you.
Who's first? Go ahead.
I like that all your objectives are data-driven. First of all, congratulations on getting this far. I think that there would
So first of all, we hate the word noncompliance, just because that intimates that perhaps there's something wrong with the patient. The way I describe that is the patient's medical agenda does not match up with my medical agenda for the patient. So that's a more politically correct way of talking about it. The best way to think about it is we incent per site, not per individual physician. So if I have a patient whose A1C is 12 and no matter what I do, I'm not going to get it better. So I'm like, you better see my partner, Dr. Kemberling. I haven't helped us at all because it's still in the practice. We do not discharge for the noncompliance. What we do is we have a set of goals and I sit down with the patient and our case managers help us with this. What do you want to work on? What's bothering you most about your disease? These are the 5 things I think you need to work on. Pick one. And I use as an example, I have a diabetic patient who loves coffee and donut in the morning. He goes to Dunkin' Donuts every morning. That's where he sits. If I told him not to have that donut, he's never coming back to see me. He's not going to stop going and having a donut with his friends. So I'm like, leave that alone. How about we give you a little more insulin knowing that you're going to do that every day? And in response, because I'm going to let you do that, I want you to do this and count carbs for the rest of the day. A little bit of a give and take. And, you know, his A1C is down from 12 down to 9 right now. So a little bit of give and take. But it's not easy. There are patients that have the best intentions. They still don't want to comply with what we want. They still need a doctor, though. Yes?
I have a 2-part question. How engaged are your employers in your service area? And then also, have they seen any improvements in terms of some of the cost of their group health?
So we actually got our first local employer to engage in medical home, and it's Woodmode. They make cabinets. They're one of the larger employers in our area outside of the health systems. And they have a new plan that comes through that if the patients are seen at a medical home site, they pay lower premiums. We've also put out some of the healthcare and preventive care visits out to those sites. We do some what are called health visits. So if a patient has high blood pressure and they record their blood pressure and they get them at goal, they get $200. And that's for anybody that has the insurance. And so we have a couple programs like that out in the employers. So the data for how much improved, I don't know. The contract with Woodmode just started, so hopefully within the year or so we'll have some data to show that that does work and more employers will take that up. Yes?
Yep. We see a lot of behavioral health issues showing up in primary care, and we're looking for models constantly that can manage those patients better, are aligned with these kinds of stuff.
Behavioral health is a universal issue.
Right.
We are piloting right now for children with behavioral health issues because they use the emergency room 2 or 3 times more than any other child. So we actually are putting a psychologist and a fellow in the primary care sites to see these patients, again, close to home, so that you can touch, because patients don't want to drive to see a specialist. They perceive that there's something wrong. So she essentially has some scheduled visits, and then if a patient comes in, not to see me because I don't see children, but for example, my nurse practitioner, Mary Lynn, 12-year-old behavior problems, she can get Tanya, our psychologist, who will come and see the patient right then and there and help with that. So that's in a pilot. She's been there for 2 months now.